Welcome back. Just like the last session, you heard that Dr. Delone had been instrumental to the Parekh Family Foundation work in India. So too has Rajiv Shah. He has been there from the first time we were in India and ever since, and has really been the cornerstone for foot and ankle in India. So it gives me great pleasure to have Rajiv Shah moderating the session on neglected foot and ankle injuries. Rajiv, it's all yours.
Thank you, Selene, and thank you very much for having us here. I'm going to share my screen. I hope I'm audible and my screen visible. Okay, so this is a session on neglected foot and ankle injuries where we are going to cover ankle, calcaneus, and talus. And before I start, a very big thank you to Dr. Selene, and together with him, we have been instrumental in doing 11 annual Parekh Family Foundation foot and ankle meetings in India, 4 mid-year Parekh Family Foundation meetings, and an African Parekh Foundation foot and ankle meeting. And we trained more than 3,000 orthopedic surgeons. So Selene not only is a good friend, is a mentor too. And I have a fantastic set of panelists. We have Professor Chua, who is from Malaysia, a senior orthopedic foot and ankle surgeon, who is also vice chairman of Asia Pacific Foot and Ankle Council, sitting with me. Professor Nuri is from Turkey, and he's also a very senior foot and ankle surgeon, has done phenomenal work into ankle replacement and hallux surgeries. Welcome, Professor. Professor Ming is present president of Hong Kong Foot and Ankle Society and also a council member with me in Asia Pacific Foot and Ankle Council. And Professor Andri is from Indonesia, a young dynamic foot and ankle surgeon who also is treasurer of Asia Pacific Foot and Ankle Society Association. So without wasting much time, I'll just share one case and then I'm going to hand it over to other panelists. So what do essentially we mean by neglected injuries? It is either a missed injury or injury which is untreated or injury which is poorly managed. All of this fall into neglected injuries. And this was a case of a gynecologist who sustained fall from stairs and a closed left ankle injury. And these are the x-rays. So Professor Nuri, how would you go about this case, a closed injury in an active gynecologist? Professor Nuri?
Right. Thank you, Rajiv. This is a commonly misdiagnosed or missed injury, which includes the syndesmosis. So we should be very cautious about because obviously the medial clear space is increased a lot. So we should be very cautious not to miss the syndesmotic injury in this patient.
Very well said, Professor. And look at this. This were the skin conditions. And the fortunate or unfortunate story with this lady was that husband was an orthopedic surgeon. Husband is orthopedic surgeon. So this was considered as a simple ankle fracture. And Professor Chua, what should be the treatment for this so-called simple ankle fracture?
Yeah, for this case, I think there is a shortening of the fibula and also displaced fractures. So I would offer the patient operative by doing the open reduction and internal fixation with a plate and check the syndesmosis during the surgery.
Okay, so do you get some specific views before you go in for this surgery?
Yeah, if anything more than this view, I would do a CT scan. But of course, you can do a stress view on this foot to determine whether these are stable or unstable fractures.
Okay, so this was treated with closed reduction and percutaneous MIS fixation. The screw was also fixed percutaneously and a rationale was also pushed in percutaneously. Professor Andri, your comments onto this fixation and what problems you anticipate?
Thank you. Problems I can list is the fibula is still shortened. You can see the disrupted of the dime sign. So I suggest to lengthen the fibula to restore the fibular length. That's my opinion.
Okay. Okay. So obviously all of us agree that this should not have been done. Any other point, Professor Ming, you want to put forward? So one point is with relating to the fibular fixation. Any point you want to put forward for medial malleolar fixation? Professor Ming?
For the medial malleolus, in fact, there's no significant displacement and quite reduced, well reduced. Is a less screw to fix the medial malleolus. Is no intra-articular steps. I agree that the for the fibula is rotated, shortened, and mal-reduced. Okay, it should be we have a reason for the fibular fracture, and the medial case space is a widened.
Okay, so she was mobilized at 4 weeks. Weight bearing was started at 6 to 8 weeks, and this were the X-rays after 1.5 years when she presented to me. But for what she presented to me? 1.5 years post surgery, she had a lot of medial pain, a lot of difficulty in walking, and she found to have a progressive deformity at ankle and foot. And this is the back view of this lady, and these are the views you see. So there is a hindfoot valgus and a unilateral flat arch. So Professor Nuri, what should be the treatment at this juncture and what went wrong?
Actually, in the early phase of the treatment, we should not be accepting this malreduction. We should go for an open surgery. Everybody likes to use the minimal invasive techniques, but it's true as long as you get a good result. And if you don't get a good result, you should stick to the traditional treatment methods. And we should be fixing the lateral malleolus with an open reduction and anatomic reduction and internal fixation. And also we should be addressing the syndesmotic screw for the stability.
So any of the panelists, anything else might have gone wrong in this case? Anything you suspect? Yes, fibula is okay. Any suspicion, anything might have gone wrong with this patient having unilateral flat foot? Professor Chua, Professor Andri, Professor Ming. Okay, for the want of time, this is what I thought has gone wrong. And the screw which was pushed on a medial side was through the tibialis posterior tendon. That also augmented the issue. So it was diagnosed as a case with an iatrogenic injury to tibialis posterior tendon leading to TP rupture plus a malunion, heel valgus, medial side laxity. And then when I took him on exploration, when I opened the tibialis posterior sheath, you can see the screw which was passed through the tibialis posterior tendon, and that's the slit in the tendon through which the screw had gone in, and the complete tear of the tendon. Professor Chua, so there is a tibialis posterior insufficiency plus a malunited fracture. How would you go ahead? 1.5 years post injury, post surgery.
Wow, this is a nice case. Okay, So you remove the screw. I think the lateral malleolus need to address as well to decrease the, reduce the malrotation and put the plate. And also the tibialis posterior, if there's a very insufficient, you can try to repair. If it's not possible because of the fibrous tissue, then you may need to use other tendon transfer like FDL, flexor digitorum longus, to replace or added to the posterior tibialis to correct the flat fit.
Okay. Yeah. And anything for medial sided ligament? You anticipate any issues with the ligament?
The ligament look like from the X-ray, the medial space is not increased. So the deltoid ligament should be intact in this case.
Okay. So I'm just moving forward with this case. So tibialis posterior was degenerated, flexor digitorum longus transfer was done. Even the deltoid ligament was absolutely lax, and then deltoid was also reconstructed and FDL transfer was done. I also added medial calcaneus slide osteotomy as a first procedure because I wanted to do the correction beforehand. And this is how the postoperative images looked. I did not do anything to the fibula except that malunion. And she has gone back to work and is now daily operating cases. So any comments, Professor Andri?
No more comment. It's perfectly done.
Yeah. Okay. Anything different you would have done, Professor Ming?
I will do the similar procedure. Yeah.
Okay.
I have one question. Why
Yes,
you don't remove
Professor.
the rush rod at the second, revised operation?
Yeah. So, yeah, it could have been removed, but it was not removed anyway.
Because most of the time the rush rod may cause a subfibular impingement over the area.
Okay. Yeah, but the most important story was husband being an orthopedic surgeon in and around into the operating room, guiding and directing me. Anyways, so next case would be by Professor Nuri. So Professor, please go ahead and share your screen. I have stopped sharing my screen already.
All right. I start sharing my screen. Is it okay?
Yes.
All right. This is a 25 years old male who fell from height and operated for a vertebral fracture after this fall. And he came to us 3 months after his initial trauma. And he came to us with these external fixator in place, and percutaneous K-wires also can be seen here. And he says that he did not want an arthrodesis, which was offered to him in his by his previous doctors. So when we took his X-rays upon his arrival, we see that it's a problem of both the bone and also the cartilage. There was a big combination of the talus. The medial malleolar fracture was not very well reduced at the first operation. And as 3 months have already passed, he had started osteoporosis. We asked for his previous X-rays. He was coming from a long way, so he could only supply us these 2 X-rays, which were taken in the emergency department after his fall. And we see that in the previous injury, in his first injury, he had an open fracture dislocation, and there's a big amount of proximal and posterior displacement of the medial malleolar fragment, and half of the talus was also displaced proximally with this high energy trauma. So we started taking out everything, which means we just took off these K wires, and we also removed the external fixator. And to decide for the treatment, we started investigating, and while waiting for a few days for the pin tracts to heal, we started a calcaneus traction, the traditional method. And that day we also took a CT scan of the patient. Here we can see that the malleolar fragment is not healed and also malreduced. And also there's a big combination of the talus, as you can see on this CT video. And this is also to give you some more information, 3D reconstruction of the CT. So we plan to reconstruct the medial malleolus, but we should also be reconstructing the articular surface of the talus.
Professor Nuri, sorry to stop you, but
Yes.
would you wish to take opinion of any panelist? Professor Chua, what would you do? Can you go back to one slide? Yeah. Professor Chua,
Yes.
how would you proceed with this case, with this CT scan?
Okay. Is there any open wound like this? But if it's the soft tissue is allow us to do the open reduction, then we may go in for the internal fixation. You might go into the CT scan there. So in this case, we can take advantages of the fracture medial malleolus to settle the talus as well. I mean the CT scan of the recon view, please. Yeah, just swing over there. Yeah, you can see there's half of the talus body actually is shunted along with the medial malleolus. So we can go for the medial approach and then to elevate the fracture medial malleolus because it already fractured. So we take advantage of not doing the medial malleolus osteotomy, and at the same time, at that approach, you can go and reduce the talus and put the screw fixation. If necessary, put a tailor plate and then use a screw to fix the medial malleolus. I think
Okay.
screw is good enough rather than just do the buttress plating on the medial malleolus.
Professor Ming, would you fix this osteotomy or the medial malleolus fracture with a screw or a plate?
I prefer a plate as a buttress plate, which is biomechanically better than screws. Because it's 3 months after the injury, the bone may be a bit also paining. Yeah.
So Professor Nuri, please go ahead. What you did?
All right, these are the pictures taken during the operation. As my friend Dr. Chua has nicely said, we took advantage of the medial malleolar fracture. It was just like an osteotomy to reach to the talus. So we could be easily reaching the talus without the need for any distraction. So here at this stage, we see that there were still 2 big pieces of talar dome, which you can see on the right here, moved posteriorly out of the joint. And these 2 big pieces could be used as the main parts of the reconstruction, which can be fixed to the talar body with headless screws. So we go through it, and as you can see here, we use the headless screws and try to reconstruct the talus as possible. But because of the delayed presentation of the patient after 3 months, there were some also bone loss and cartilage loss, and we tried to cover these lost cartilage with scaffolds. And the scaffolds that we used were, this one was a hyaluronic acid scaffold, which was not enough to cover all of the surface. So we also added a collagen scaffold for the defects. And we used the fibrin glue to fix these scaffolds to form a joint. So we could achieve an acceptable result, but not the best result. So we could, you could see that the fracture is nicely reduced, and we have the scaffolds here. And now we also fixed the medial malleolar fragment. 2 screws were fine, so we didn't go for using a plate because it was an open fracture previously, and he had a lot of wound problems. But at this stage, still we were not very comfortable because we know that the cartilage pieces were out of the joint for 3 months. It will get a lot of time for them to heal. And also we need to do something more to achieve a joint alignment. So maybe you can also we can also ask my friends, my colleagues, what to do next, or is it the end of the operation?
Yeah, Professor Ming, anything you can do at this juncture?
I think that for the loss of the cartilage on the middle dome of the talus is a maybe a difficult issue. In fact, if the lateral side is normal, I think that we can also may if do the microfracture or to promote the healing of the fibrocartilage on the middle side. Although if there is a severe degeneration, we can do the may consider the supramalleotomy to shift the load to the lateral side from the middle side. Yeah.
Professor Chua?
I think at this moment, I will just leave it with this, but maybe I will use the external fixator to distract the joint so that the talus cartilage can heal properly. Because without distracting the joint, the joint may compress again. That's minimum thing that I will do. I will not add it to any more damage.
Okay, Professor Nuri, Dr. Chua read your mind. Go ahead, please.
Yeah, he's right. I know that he's very keen surgeon with the external fixators. So we also use the same method, and we use an external fixator at Ilizarov frame, a circular external fixator, to achieve an arthrodiastasis effect, to give a chance for the cartilage and our scaffolds here to heal. So this is a picture of the patient, and this is the early postoperative picture. And then we started distraction, and we followed our distraction with these X-rays. And after 10 days, we started, the patient was encouraged to start ankle motion. And this is one of the videos he sent to us on his follow-up. And this is postoperative 6 weeks and postoperative 3 months. We get a nice result of the reconstruction of the joint. So we decided to take out the fixator now. And these X-rays are just after taking out of the fixator. And on the follow-up, these are his X-rays on postoperative 8 months. He had a good alignment, and he has ankle joint space was nicely improved. And he was quite happy with the results, but we are still following him. Thank you.
Thank you, Professor Nuri. A great case. If you could stop sharing your screen. Professor Andri, could you start with sharing your screen?
Yes,
and
sure.
present your cases, please?
Thank you. First of all, I would like to thank Dr. Selene and Dr. Rajiv for this opportunity to participate in this tremendous meeting. Is my slide can be seen? Okay. as has been described perfectly by Dr. Rajiv about the neglected injuries, that the cause of the neglected injuries is not only traditionally it's because the patients do not seek treatment or against medical advice, but it can be also caused by the delayed treatment, for example, by the distance or if the patient had some contraindication for surgery or treatment. Or if the treatment is suboptimal, for example, in the related to the surgeon's capability and the hospital facility. So the neglected injuries will result in malunion, soft tissue problem, infection, necrosis, nerve problem, you name it, and it will result in functional impairment. So the other question is, can we restore the anatomical structure? Can we restore the function or neither of the anatomic and function? So in contrary with the phrase case, in which we can restore the anatomic and range of motion, in neglected case, there are some derangement of the bone, articular surface, and soft tissue. So we have to change the goal, not only restoring the anatomy, but maybe we have to lower our standard into the, or my concern about the painless, stable, and plantigrade foot. I will show you some cases from my hospitals. I will share it briefly to the remaining time. This is the first case about neglected posterior subtalar dislocation. Actually, if it's the first case, it's not too difficult to reduce, but the patient is have the neglected cases due to the underdiagnosis, because as you can see, the clinical picture is not too prominent. So the first caregiver didn't take this as a dislocation. Instead, they just consider it as a ankle sprain, and then after 1 or 2 weeks, the patients come back again, have the X-ray, and get this view. So, if in contrary with the phrase case, there are another problem about the difficulty of the reduction and soft tissue compromise. When the phrase case can be reduced by close method, there are some problem in the neglected cases. We have to reduce it openly, not only to lengthen some contracted tissue, but also if there's some buttonholing talar head into the extensor tendon, so we have to reduce it openly. And also we have to put another fixation because we have released some soft tissue for reduction. Another case, this is the neglected Achilles tendon rupture. The main cause is because the patients against medical advice, and then after 5 months, he came back with the gap more than 5 centimeters, and patients complaining about the difficulty of walking. So when in the phrase case, the tendon can be repaired easily, even with the minimal invasive technique. In the neglected case, you have to do it more in a much more larger incision, because you need to release the soft tissue, to find the stump, and then to do some kind of VY advancement and tendon transfer. The goal in this patient is the functional restoration. We need augmentation, not only about how to reattach the between stump. Another case, interesting case. This is the neglected lateral malleus fractures.
Professor Andri.
Yes.
Professor Andri, can I just stop you? In your first case, what difficulties did you face when you went through the medial approach to reduce the head of the talus? And how did you reduce the head of the talus?
Yes, thank you. Firstly, I tried to reduce it closely, but it seems there are some obstacle in which the talar head is buttonholing to the extensor tendon. So we have to release at the medial side, and then the Achilles and the posterior soft tissue is contracted because there's another severe swelling. So I need these 2 incisions. Any comment?
Yeah. The only thing, just a tip on to reducing the talonavicular joint, if you can give to our delegates.
Yes. Can I proceed to?
Yeah, please.
Yeah. The cases is the malunion fracture in the growing bone that result in imbalance growth. So there are growth arrests in the lateral side, resulting in the valgus ankle. This is the 5 years onset. The cause of the neglect is the patients against medical advice. And now, when the patients came back, there are some anatomical changes, but with the fibular shortening relative to the medial side and some kind of tibiofibular synostosis. Considering the cartilage is still good, we try to do the joint preserving technique other than joint sacrificing. So fortunately, we can restore the anatomical axis and mechanical axis, just like seen in here. And the range of motion is restored, mortis, and also not only mechanical axis, but anatomical axis are also restored. Different with this case, we have another case more severe, because the fracture is much more displaced, and for some reason we cannot restore the anatomical axis because the scarring of the tissue, there are wounds at the lateral side, and also some degree of arthropfibrosis and articular damage. Actually, this is the patient. The patient is candidate for arthrodesis, but we try to restore the mechanical axis, maybe to avoid or delay the joint sacrificing procedure. For these patients, we do the supramalar osteotomy, fibular osteotomy, and then translation to the medial side. Yeah, we can restore the mortis, the motion as well, but we cannot preserve the anatomical axis. Instead, the mechanical axis is restored. The patients can walk more functionally. Next case, this is more severe case. The patient came with neglected talar fracture and end-stage PTOA. Again, the problem is against medical advice. So the patient came with the deformed and non-functional foot. The problem here is periarticular destruction, and also there's a degree of anterior talar translation. So this is candidate for the joint sacrificing procedure, and we treat this patient as with the ankle arthrodesis with anterior plate. The goal is mechanical axis restoration, and stable and plantigrade ankle is achieved. Next case, actually it is not the hind foot case, but rather is forefoot.
So you can skip this case. You can skip this case. Yeah.
Okay.
Go with the next case.
Yeah. The seventh case, the severe equinus due to the suboptimal treatment. The first caregiver just treat the open fracture of distal tibia fibula, and then the patient have the problem of the severe equinus. If you can see, the wound is healed, maybe the fracture is healed, but it seems the equinus is not one of the concern of the first caregiver. So actually, in my opinion, I would like to amputate transtibial amputation, and then followed by orthosis, but the patient refused that option. So we try to treat the equinus, and we do the gradual correction with the circular frame, and the patients, although this is not fully plantigrade, but the patients can walk functionally with some shoe lift. If the soft tissue is permitting, we can do one stage correction like this. We have done the Lambri-Nuti procedure and followed by tibiotal local canal fusion by plate. As summary, it's different between fresh case and neglected case. When in fresh case, we can restore the anatomy and range of motion and so on. But in neglected case, we have to set our goal, maybe lower our standard, not to restore the anatomy, but painless, stable, and plantigrade is needed, because our goal is maybe we can tell the patient maybe the foot and ankle is not normal but functional. Thank you for your attention.
Excellent, excellent presentation. Great cases, Professor Andri. And can I ask you to share your screen, and Professor Ming, yes, can you start with your case and involve other panelists into your case with your questions, please.
Okay, I would like to share a case of negated fracture. Okay, a 71-year-old retired construction site worker compared left ankle pain for 21 years. In fact, in 1992, he had an ankle sprain, then compared left ankle pain and seen by a bone setter. At that time, there's no immobilization of the ankle, and he was not able to work for 5 months. The pain is mechanical in nature, and more than 10 years later, he compared a severe left ankle pain, walk with a stick slowly, to a walking tolerance about 1 hour only, with a pain on mostly at the lateral ankle region. The range of motion was still quite good. It showed the X-ray in 2013. Would Professor Chua try describe the X-ray and the management?
Professor Nuri? Professor Nuri, how would you manage this?
Excuse me.
Yeah,
Can
say
you
this
go
again, please.
one slide, previous slide, please, Dr. Siu?
Yes. It's about nearly 20 years ago. Yeah, 21 years ago. Yeah.
Yeah. So here we see a big amount of sclerosis at the talus, with a possible fracture line through the talus, and we also see the ankle joint osteophytes, and anteriorly mostly, and also we see that there is some subtalar joint osteoarthrosis.
Oh,
So
yes.
did she have a trauma?
Yes, a ankle sprain 21 years ago. Okay, with a pain, but not consulted the physician for the treatment. Yeah.
So after this long period, he was painless and no symptoms, right?
In the past, only felt mild degree of pain. However, in the recently at the 2013, there's a severe pain. In fact, there's
So we can see that it's a slow onset of vascular necrosis of the talus, in my opinion.
Okay, I'll show you the CT scan. Okay, so in fact, there's a fracture of the body of the talus, and that's associated with some degeneration, some ossify formation at the anterior part of the ankle joint, and Professor Heybeli, that what is your plan or treatment for this gentleman?
So this is a case like, for instance, we see sometimes because of the long use of biphosphonates, we see some stress fractures through cortical bone, which is very hard. So because of the vascular necrosis of the talus, as the talus is not elastic and lost of most of its spongious cancellous bone, I think it's a pathological kind of fracture. Although it's non-displaced, I think that it will not be easy for it to heal without operative interventions. So although it's a non-displaced fracture, I think we need to use some additional measures for the talus bone to heal, like, for instance, percutaneous compression screws, or even maybe we can use some more biological adjuncts to increase healing, because I'm sure that the healing will be slow if we do not do these kind of measures.
And Professor Chua, your opinion, please.
Yeah, my opinion is the patient is 71 years old. So with this type of query, avascular necrosis of the talus, and the subtalar joint is arthritic. The ankle joint also look arthritic with the anterior impingement. Whether we want to salvage the joint or fuse the joint. Because the patient is 71 years old, I will actually fuse the high foot joint, the subtalar and the ankle joint, and then have a stable, painless ankle to walk for his age.
And Professor Andri?
Yes. Considering the age of the patient and the demand, I assume with the 71 years old, maybe she is a low demand patient. So the goal is we have to set up the goal. I think for her, the stable plantigrade is enough. And this is considering this is a AVN of the talar dome with the ankle joint arthritis, subtalar arthritis. I think arthrodesis is the option because I also considering the previous trauma. Why this fracture is go unnoticed? Maybe it's not because not only about the misdiagnosis, but of course another reason. Maybe the patient have some neuropathic foot, so the pain from the first trauma is went unnoticed. So that's why I think the goal now is a stable plantigrade foot and with more protection to the ankle and foot. My opinion.
Professor Ming, if you want my opinion, if this patient wants movement,
please comment about this case. Yes.
Yeah. So if this patient wants movements, and if his age is little less, I would have definitely gone for total talus replacement. In this case, a 3D printed total talus replacement, which has worked very well, at least for the medium term results in my hands. Let's see what you did.
Okay. From this CT scan, although some views showed increase in sclerosis of the body on the middle side of the dome, but on other parts of the CT scan, still the that bone cell density is still comparable with other bones. Okay. In fact, the patient wants some motion of the ankle. Here, so the reconstruction, so the fracture here, non-Uterine. So the CT scan reports showing the old non-Uterine fracture of the mid-talus body. Okay, with some ossified formation, mainly at the marginal ossifys. Okay. In fact, okay, I did the open reduction interfixation of the fracture talus non-Uterine with bone graft. In fact, the fracture surface was sclerotic, and however, there's some bleeding from the edge of the fracture site when after drilling for very shallow drilling. Okay, so there's a still viable bone. Yeah. In fact, there's some impingement of the anterior talar fragment with the fibula because it is displaced. Okay, so I perform the dual approach and to put the antomedial and anterolateral approach to including the medial malleolar ostomy to reduce the fracture. Also to remove the sclerotic bone and drill the non-Uterine site. Okay, the bone graft is from the proximal tibia, and the fixed with a 3 mm atlas compression screw. Here, so the inch-off photo with the middle molar or something performed, you can see the body and the fracture, the border taters and fracture clearly here. So under fluoroscopy, I insert the guide pins and also the cannulated screw headless. The final result, in fact, also fixed back the middle molars. Yeah. So the patient was put on a brace and non-weight bearing walking for 10 weeks time, and about 5 months can walk unaided, and also full weight bearing walking, and at about 2 years, in fact, follow-up, there's only very minimal pain. It showed the X-ray at 3 months time, and the 6 months, in fact, 18 months, this is so urinary of the non-urinary site. Okay.
Thank you.
And 2 years. Okay. That's okay. I think.
Thank you very much. Thank you very much, Professor Ming, for a great case. Can I ask you to stop sharing your screen, and Professor Chua, can you go ahead quickly with your case?
Yeah, sure. Thanks, Rajiv. So I have this case, 45 years old, have history of trauma 20 years ago, and they have some previous surgery, which he also not sure what surgery was that. And this is the how he come with the painful gait and high foot valgus. So this is an X-ray. So, Siu, what you want to do for this patient?
It's so a fair valgus ankle with degeneration. I think it may be due to the old injury, the fracture. Okay, for this case, there's severe degeneration with malalignment of the ankle joint. For the subtalar, it's difficult to appreciate at this X-ray. I think we need a fusion of the ankle, or I also need to evaluate the subtalar joint with a CT scan, okay, to secure the about any involvement, okay.
Sure.
For the ankle joint, if you do realignment, in neutral alignment, also fuse it, and okay. May I have the CT scan?
Yeah. Before we go to CT scan, Rajiv, you want to give any plan for this patient with just the X-ray? Yes, Rajiv.
Yeah, I would want CT scan anyways, because this
okay.
is not.
Okay, you want a CT scan. So,
Yeah.
okay, let you give you the CT scan. Yeah. Any comment or any plan now after the CT scan? Yes, Rajiv.
Yeah, it does look like a global arthritis in my country. With my kind of patient, definitely I'll go ahead for ankle fusion. But I know at the same time you could try a supramalleolar osteotomy as well as in a calcaneal osteotomy and try to correct the axis, and because there is a focal loss of cartilage, you could try to salvage this ankle, and it would be interesting to learn what you did.
Okay. How about Nurettin?
Yeah, Professor Nuri.
Although I am a big fan of saving the ankle joints. This joint it doesn't seem to me as savable. So a good, nicely aligned ankle fusion by saving the subtalar joint will be a good option for this patient, in my opinion.
Right. How about Andri?
Yes. If just look to the X-ray and CT scan, I don't think the joints can be preserved. But considering the patient, from your clinical videos, the patient still can walk without no notable pain. I think because this is the young patient, I would like to realign first and then delay the arthrodesis or arthroplasty later. But
Sure.
first, we need to realign the joint first.
Yeah, okay. So this patient is just spread up with the many operations have been done before. So he come to me, he say, doctor, I give you one chance that I want to walk well. Hence, I use a lateral approach to cut the medial malleolus and try to align the ankle and thinking of trying to save the subtalar joint. However, after aligning the ankle, the cartilage, of course, the ankle joint is all wear off. And then I still not able to align the ankle very well. Hence, I have to sacrifice the subtalar joint by using the high foot nail to get all the alignment. So this is a post-op X-ray, and this before and after, and this is a clinical picture of the patient before and after, and also the gait before and after the surgery, about 6 months. And he is quite happy. Any comment? Or else
think
I
great.
was, yeah.
Yeah, it's a
Yeah.
great job. And you see, we can go on discussing on to neglected injuries for hours together, but because of the paucity of time, we will have to just go ahead with one or two cases of mine. So, so this is a case of a manual laborer who had a fall from height, bilateral injury, compound injury on the left, which was managed with skin grafting, and all fractures were managed conservatively. So these are the X-rays 15 days post-injury. So that's the right side, that's the left side. And these are the X-rays at the 3 months. And now this is at 11 months when he comes to meet me. This is on the left side. That's on the left side, weight bearing X-ray. And on the right, and that's the left side skin condition. There's a skin grafting done for an open injury which has healed. That's left-sided picture. And the right side, this is the right-sided X-ray, lateral view. That's the foot looking like on the right side. And these are the axial images, left and right. And these are the clinical pictures. So for the want of the time, I'm going to go ahead with the CT images. And this is how he was walking. On the right side, he was really not able to put the weight down. And so these are the CT images on right side. Malunited calcaneus. And that's the CT image of right side. And this CT on the left side where you find that there is empty ankle. You don't find talus, which was probably lost or removed. We don't have the previous papers. And yeah, that's the left side. So what next for the right side, Professor Chua?
Actually, I confused with the right and the left side now.
Yeah.
So we are talking of one side is equinus and shortening.
Yeah. So we are talking about the side where you don't have equinus. This is the side we are talking about, the left side.
Don't have the equinus. Actually, the patient is walking well with the left side, which
this
I
is
think
what we are talking about, left side. Yeah, this is the X-ray.
Yeah, he is walking well with the left side, but the right side is not
painful
walking
also.
well.
He's painful on the left side as well as painful on the right side.
Yes, but I think the problem is the right side, which have a shortening and equinus that can make her gait abnormal, which causing the pain on the left side. So I will address the right side first to get the equinus down and the plantigrade and the shortening. for him to have the balance gait. Then if the left side still got pain, then I will only address the left side. Because I think obviously the problem now is the right side, which have severe equinus and a shortening. Yeah.
Okay. So for right side, you would do what?
I would use a ring fixator Talus spatial frame to distract it and also correct the equinus. And if I can get a space, then well, I don't have the facility for doing a total Talus replacement like your center. So if you're able to distract and correct the equinus down, I think by using external fixator, you should be able, because it's a gradual lengthening. And then if you got a space, you can put the Talus that you have in back.
Okay. So Professor Andri, how would you approach the right-sided, right-sided ankle? Yeah.
Yeah, we have to concern about the patient's complaint. If the pain, I think it's because the equinus and the more pressure on the forefoot. So I agree with Dr. Chua. We have to restore the equinus and then stabilize. And if the patient still feel pain, again, I think we have to examine truly. Maybe the pain is not because the equinus only or the instability, but also considering this trauma, maybe it is another kind of CRPS.
Okay, and what would you do for the left side? That's also
for the left side. Yeah, I think the alignment is acceptable. It's plantigrade. Maybe the pain is come from instability. So I will fix. If not for the realignment, I will fix the tibiotalar. That's
okay. So there is a dorsiflexion of talus. Now we have just a minute or so. So I'll just rush through this case.
Yeah, we have less than a minute. So if you can just go right to the finals, that'd be great.
Yeah. So yes, obviously the left side had subtalar osteoarthritis with lateral wall exostosis and dorsiflex talus into the ankle. And left side was treated with open tendo-Achilles lengthening and distraction bone block fusion, fixed like this. Right side had a equinus, loss of talus, varus. So it was opened with a lateral extensile approach. Fibula was used as a TTC nail and compression screws plus anterior plate. Bridging navicular to the tibia, and this is how surgery on the right side was done. So we'll stop here. And any comments, any questions, Selene, if you have, or nope. I'll hand it over to you.
No, you guys, excellent job, Rajiv. Fantastic cases that you guys all have. Thanks for joining.
Thank you.
We've learned quite a bit, and we will take a break for a few moments and be right back.
Thank you for involving us. Thank you very much.
Thanks, everybody.